Good morning, everyone. So I am presenting today this topic, antibody-mediated rejection in pediatric liver transplant patients. So I will give my talk under these headings. So we do not have a confirmed case of antibody-mediated rejection, but with the case scenario which I am presenting, I will show that when should we actually suspect antibody-mediated rejection, what is the pathogenesis, and why liver is a tolerogenic organ, and what is the prevalence of antibody-mediated rejection in liver transplant recipients, adult and pediatric, how to diagnose, and what are the treatment strategies. So first, coming to the case scenario. So this is a child with biliary atresia post-Kasai, recurrent cholangitis, portal hypertension. So he was transplanted at an outside center in 2012. So there was no vascular biliary issue. GRWR was 1.39. And subsequently he had cellular rejection, so he was treated with steroids, and subsequent biopsy did not show any rejection, but there was gradual resolution of transaminases. And 2 years later he had persistent graft dysfunction, which I will be showing in the coming slides. When he came to us in 2018, he had splenomegaly, endoscopy did not show any varices. Lab reports showed persistent elevation of AST/ALT 4 to 6 times upper limit of normal. Alkaline phosphatase and GGT were just borderline 1 to 2 times, and IgG levels were quite high. Autoantibodies were negative, and viral markers were also negative. So he was on triple immunosuppression. So there was adjustment in the TAC and MMF which were done because of renal dysfunction. So this is the enzyme level, persistently AST/ALT elevation. So he received multiple pulses. MMF was also, he was also on MMF, which was stopped because of cytopenias. Here again we can see from 2016 to 18 persistently high transaminases. So TAC dose even went up to 7 milligram BD, which was quite high. So he developed renal dysfunction due to tacrolimus. Even at some point of time everolimus was also tried. So this table shows the biopsy features in this particular patient. So the portal inflammation, the lymphocytes were there, plasma cells, lymphoid aggregates. Central paravenulitis, which is a feature of late acute rejections, was not there. There was no vasculopathy. Fibrosis was progressive from F1 to bridging. Donor-specific antibodies were documented only once when they were positive, and C4D staining was absent in 3 of the biopsies. Macrovascular damage was present only in 1 of the biopsy, and interface hepatitis was present in the last 2 biopsy. So overall, the repeat biopsy which we did, there was no evidence of antibody-mediated rejection. So immunosuppression was adjusted, but when he did not show any response, he was also given anti-thymocyte globulin. So, but there was no response even after 1.5 years of receiving ATG. So he was listed for re-liver transplant, and subsequently he lost to follow-up. So about the outcome of pediatric liver grafts. So this was a case with abnormal transaminases, but even with normal transaminases, so they may have an abnormal histology in the protocol biopsy. So 40 to 70% as per different literatures now, they show that they may have chronic hepatitis and fibrosis, and some of these may be antibody mediated. So about retransplant, so chronic rejection, some of them may be antibody mediated, is an important cause in around 15% of for retransplants. So about the risk factors of liver allograft rejection. So this is a study in adults where they have shown that HLA mismatch is an important predictor for recurrent allograft rejection apart from autoimmune disease and younger age. So what are the lessons from renal transplant? Because in the renal transplant setting, it is the antibody-mediated rejection is more common, so which is seen in around 10% of the renal transplant patients, and 30% of these patients may lose their grafts. So graft survival is poor when there is AMR in a renal transplant setting. And this AMR is mediated by antibodies against the MHC antigens, human leukocyte antigens, donor-specific antibodies which lead to complement activation, vascular changes, and graft loss. So apart from HLA, sometimes these antibodies are also directed against ABO antigens, endothelial cell antigens, or rarely angiotensin II type 1 receptor. So 3 types of AMR are described: hyperacute, acute, and chronic. So hyperacute happens within minutes to hours, where there is necrosis and thrombosis, and these patients require retransplant. Acute happens within days to weeks due to preformed or de novo donor-specific antibodies. So if the patients are already sensitized, so there is risk up to around more than half of the patient, they have worse prognosis. And chronic CMR happens in months to years, where there is persistent DSA positivity leading to chronic antibody-mediated rejection, with almost up to 60% patients losing their grafts. So briefly about human leukocyte antigen. So this MHC complex is located on the chromosome 6p, and there are the three different types: MHC1, which encodes for three antigens A, B, and C. MHC2 is for DP, DQ, and DR, and the subtypes are DM, DN, and DO. And class 3 is the complement proteins. So overall, these HLA antigens are responsible for adaptive and innate immunity, infections, autoimmunity, and also very important in the transplant setting. So class 1 antigens, so they are presented by the viral infected T cells to the CD8 cells, leading to leading to the cytotoxicity, whereas the MSC class 2 antigens are presented by the antigen presenting cells to the CD4 cells, leading to the cell mediated injury. So there is antigen uptake, presentation, and then the effector function. So this diagram shows the mechanism of antibody mediated rejection. So due to stress, inflammation, ischemia, reperfusion, or due to the HLA mismatch, there is presentation of the HLA class 2 antigens on the endothelial surface, and then there is and with the cross reaction with the HLA class 2 antibodies, so there is complement cascade activation leading to injury to the endothelium and subsequently graft injury and graft loss. So the main mechanism here is complement activation leading to microthrombosis, fibrosis, and graft injury. So again, this diagram showing the main thing here in the antibody mediated rejection is the complement cascade activation leading to release of cytokines and both B cell and T cell activation ultimately leading to endothelial cell injury. So isolated presence of donor specific antibodies does not indicate antibody mediated rejection. There should be complement cascade activation leading to vascular injury and thrombosis. Again, this diagram showing the same thing, the complement cascade activation leading to endothelial cell injury. So there is a progression, means from donor specific antibody positivity, there is complement cascade, this activation leading to C4D positivity in the graft biopsy. There is graft injury and subsequently fibrosis. So briefly about HLA matching. So HLA matching, we should understand that even if the SIBs are there, so even if the SIB has a risk of 25% being totally non-HLA identical, 50% chance is there that the SIB may share one HLA haplotype, and 25% chance is there that they may be completely matching. So 75% chance is there that there will be risk of some HLA mismatch. So about HLA mismatch and the graft survival. So there are large series from the adults. So the first one on the left hand side shown here. So this study has shown that graft survival is not affected, but number of rejections are less with the compatible matches. And when they did the subgroup analysis, they have shown that in the primary sclerosing cholangitis there was poor graft survival when there were more than 2 HLA mismatches. And with autoimmune hepatitis and hepatitis B, there was trend towards poor graft survival. And another data in around 30,000 patients from OPTN, overall there was no effect on survival, but when 0 mismatches were compared with 6 antigen mismatches, there was better survival, and there was poor 5-year graft survival with the A locus mismatches. So now why liver is tolerogenic? So why the antibody mediated rejection is less often seen in the liver transplant setting? Because liver has a very good sinusoidal circulation, like as shown here in this picture. It has a dual blood supply, and also there is secretion of the soluble HLA antigens, and also because of predominant Kupffer cells. So Kupffer cells lead to phagocytosis of the platelet aggregates and the complement cascade, so thus avoiding the antibody mediated rejection. And also there is a homologous complement source, and also the lastly, but which is actually the most important aspect, is the ability of the liver to regenerate and thus getting rid of the antibody mediated injury. But there are certain predispositions that with the large liver there may be high level of sensitization, but also with the reduced size grafts the antibodies may cause more cytotoxicity. So both things may happen, the large liver as well as the small size livers. And also with immunosuppression there may be the Kupffer cells may be inactive, and there may be antibody targeting of the different endothelial cell antigens. So this diagram shows why liver is tolerogenic, because of the sinusoids, because of the Kupffer cells, and also because of the regenerative capacity of the liver. So what are the precipitants of antibody-mediated rejection? So if there is previous sensitization, if for multiparous females, and also previous solid organ transplantation, there is more risk of antibody-mediated rejection. And the antibodies are calculated as a panel reactive antibody to estimate the risk. So of the various series, the HLA antibodies, so this is adult data. Around the donor specific antibodies are seen in around 5 to 24% of the patient, but there is no difference with regard to an acute cellular rejection, but they are more often found in patients who have steroid resistant rejection, and there is increased risk of chronic rejection and biliary complications. So there is a list of things which can happen with the donor specific antibodies. It may be hyperacute rejection, acute AMR, or it may be early acute cellular rejection, steroid resistant rejection, chronic rejection, plasma cell hepatitis, or the other term is de novo autoimmune hepatitis, idiopathic fibrosis or accelerated fibrosis in hepatitis C patients, biliary issues, portal venopathy, and also the antibody-mediated renal graft loss in combined liver kidney transplant patients. So about the pediatric data, the DSA positivity is seen as per this study from Belgium in around 28%, mostly HLA2. Again, another series from China. The most of the antibodies here in 21%, they were HLA2, and most of them were against the DQ locus. 4 were also against the DR locus. Sorry. So in comparison to the DSA negative group, so only 3 of the patients had liver dysfunction in comparison to 10 out of the remaining 10 patients. So all were acute cellular rejection, but in the DSA negative group, in comparison to the DSA positive group, where 4 of the patients had acute antibody mediated rejection. So how were they treated? So they were 3 received plasma exchange, 1 received bortezomib, 3 rituximab, and 3 required retransplant, and there was poor graft survival with the presence of antibody mediated rejection. So this is another study from Belgium, so where they have shown that the DSA class 2 were more common, 17% versus class 1 9%, and HLA DR3 DR4 were all, and the class 2 DSA were significantly associated with more portal fibrosis, and the class 2 DSA and presence of non-HLA antibodies, that is autoantibodies, were associated with graft inflammation. So this is another data from the pediatrics from Switzerland, where again in the protocol liver biopsies were done in 44 patients, and we can see here that 40% had inflammation and fibrosis, and de novo DSA were present in up to 63% of the patients, and inflammation and fibrosis were associated with the presence of donor-specific antibodies. What about chronic AMR? So this is the data from France, so where they have looked up the fibrotic changes in the protocol liver biopsy, and they found that the DSAs were present in 45% of the patient, and the fibrosis score, perivenular fibrosis and portal inflammation, was higher in those with double DSA positivity against 2 different types of antigens, and with C4D positivity in comparison to those who were double DSA negative. So what are the methods of testing? So to look for the HLA, to look for the antibody mediated rejection, we should look for the HLA matching as well as the DSA. So HLA is done using the molecular methods with like sequence specific oligonucleotide probes, and donor specific antibodies, ideally they should be cell based on the complement dependent lymphocytotoxicity, but the commonly used method which is used by most of the centers is ELISA based, single antigen beats by flow cytometry, or the Luminex assay. And the titer of the donor specific antibodies is important. It should be mentioned as mean fluorescent intensity. So various titers have been used, so there is no standardization as such, but this particular study has mentioned that titers of more than 10,000 are strongly positive and less than 750 are negative. So donor specific antibodies, the outcome, that is the injury, depends on the antibody class, amount, specificity, the functional properties of the antibody, epitope binding, antigen density, and the location. So what is the criteria? So it is very difficult to diagnose antibody mediated rejection. So all the 4 criteria should be fulfilling. That is, histology should be suggestive of microvascular damage, DSA should be positive, C4D, there should be diffuse C4D positivity in suggesting complement cascade activation, and exclusion of the common other causes of the graft injury. So all 4 should be there: DSA, endothelial cell injury, microvasculitis, on histology, C4D positivity, and exclusion of other etiologies. So here in the slide, the right hand side, we can see the C4D positivity and how this should be done. Ideally, this should be done by indirect immunofluorescence or by immunohistochemistry. So what are the treatment options for antibody mediated rejection? So the traditional ones are steroids, or to use triple immunosuppression, adding MMF if it is not there, and using, because this is an antibody mediated thing, so we can use rituximab with IVIG, and the other options are like bortezomib, plasmapheresis, or eculizumab. So these drugs again shown here, so but we should be careful of side effects. Like for rituximab, there are infusion reactions, reactivation of hepatitis B, tuberculosis. Alemtuzumab, again cytopenias and CMV reactivation. With bortezomib, there may be bone marrow suppression, hypotension, and eculizumab, again infusion reaction and infections. Rituximab, as we all know, this is B-cell depleting antibody, not going into the details. Bortezomib acts against the plasma cells, it inhibits the proteasomes, and it leads to accumulation of the large amount of proteins within the plasma cells, leading to plasma cell apoptosis. So it basically acts against the proteasomes and leads to suppression and the apoptosis of the plasma cells, so thus decreasing the antibody formation. So what about eculizumab? Eculizumab is a C5 inhibitor, so it inhibits the complement cascade. So both the classical and the alternate pathway of the complements actually coincide on the C5 level. So eculizumab is a C5 inhibitor, so leading to suppression of the complement cascade. So this is a data on acute antibody mediated rejection in pediatric liver transplant. So this study shows that how these patients were treated. 6 of the patients who were confirmed antibody mediated rejection. So various options were tried: steroids, MMF, and 3 of the patients received plasmapheresis. All of them received IVIG, then rituximab, even ATG was also tried, bortezomib in 2 patients, and eculizumab. So here we can see the graphs. So there was response after giving IVIG and rituximab, and in 2 of the patients even there was no response even after rituximab. So bortezomib and eculizumab were also tried. Briefly about chronic antibody mediated rejection, the diagnostic criteria are almost similar. The risk factors are presence of DSA, inadequate immunosuppression, and if the MELD score is high, young age, retransplantation, and allograft fibrosis, and certain genetic predispositions which can lead to development of chronic antibody mediated rejection. Again, the data from the adults, they have shown that DSA positivity, means in terms of chronic antibody mediated rejection, is around up to 50%. C4D positivity may be there in around 15 to 30%. So there is perivenular fibrosis, obliterative portal venopathy, and with the increasing duration of the liver transplantation, there is increase in the fibrosis. So there is no consensus on how to treat chronic antibody mediated rejection. As I already showed the pediatric data, so most of the pediatric literature is on protocol liver biopsies when the liver enzymes are already normal. So there is no consensus what to treat, because how can we monitor these patients? We cannot do repeated liver biopsies, and there is no consensus on whether should we repeatedly look up the titers. Although the centers outside in UK and US, they are routinely checking their antibody titers of the donor specific antibodies when they give treatment to these patients. So the options here are the usage of alternative immunosuppression, mTOR inhibitors, again the plasma cell based therapies like IVIG, plasmapheresis, rituximab, bortezomib, or eculizumab. So this diagram shows that there are new approaches how to target the antibody mediated rejection. There may be like anti-IL-6, tocilizumab, which was used in the COVID times, and newer anti-plasma cell antibodies like daratumumab, acituximab, inebilizumab, and also C5 inhibitor, which I already said, one of them is eculizumab. So this is actually what should we actually do. So this is which we are doing, and the transplant surgeons are also following: steroid dependent or refractory rejection, which we should look for biliary causes, Then look for the what is the cause of, if it is already a proven steroid refractory. So steroid resistant rejection we label when the 2 pulses of steroid of methylprednisolone, there is no response to the steroid to 2 methylprednisolone pulses. So then we should look for biliary causes, antibody mediated rejection, or recurrence of disease, as Dr. Manoj sir has already spoken. So this is our protocol. The elevated transaminases post liver transplant, we should look for time from liver transplant, level of AST/ALT, and elevation of alkaline phosphatase and GGT. We should look whether this is early or late. AST/ALT very high, then it may suggest vascular causes. 2 to 5 times, this may be rejection or reactivation of the viral disease. And if alkaline phosphatase and GGT are high, that is a pointer towards biliary, or it may be sometimes rejection. So we should exclude vascular and biliary causes on ultrasound, Doppler, MRCP, and also check for CMV. And liver biopsy should be done. And etiology pre-transplant, that should also be looked for. So then we should divide the various causes, whether it is acute cellular rejection based on the typical triad of portal inflammation, endothelitis, duct damage, or if it is late acute rejection based on central perivenulitis, or if it is chronic rejection when there is duct loss, vasculopathy. Then finally we should think of antibody mediated rejection if there is microvascular damage and microvasculitis, fibrosis. And also we should think of recurrence of primary disease, as sir has already said. And accordingly we should treat. Like with acute cellular rejection, late acute rejection, we should give steroid pulses, triple immunosuppression, and consider sirolimus. Chronic rejection, again steroid pulse or ATG, and add sirolimus or everolimus. Then antibody mediated rejection, then plasma cell based therapies. Recurrence of AIH, increased immunosuppression, and recurrence of PSC, as sir has already said. So thus, to conclude, antibody mediated rejection is common in the setting of renal transplant, but is less common in the setting of the liver transplant. So high index of suspicion is required for pediatric liver transplant patients. And if it is refractory or recurrent acute rejection or chronic rejection, and even in the protocol liver biopsies, if there is chronic hepatitis or fibrosis, we should think of antibody mediated rejection. Donor specific antibodies, there is no standardization yet, so there should be proper standardization for the testing of donor specific antibodies. HLA matching is plus minus, whether we should do or not do. And management is basically based on antibody based therapies and plasma cell, targeting the plasma cell. Thank you. So I thank my department and also HPV surgery team, and also to Dr. Deepika, who helped me in collecting some data on antibody mediated rejection. Thank you.